So let's learn something about diabetic macular edema. So this will be part 1, and this includes its clinical features, the pathogenesis, and the investigations. So first we'll be dealing with the anatomy, then the pathogenesis, and then the investigation. So first, coming to the anatomy, we know that the neurosensory retina is made up of 3 groups of cells. One is the neurons, the second group of cells are the glial cells, and thirdly there are vascular cells. The neurons are mainly your ganglion cells, the bipolar cells, horizontal cells, amacrine cells, and the photoreceptors. The glial cells are the astrocytes, the Mueller cells, and the microglia. And the blood vessels are part of the vascular cells. These glial cells play an important role in diabetic macular edema, as these cells are responsible in providing physical support to these neurons, as well as they are involved in a number of metabolic activities. So here is a diagram that shows the extent of the Mueller cell. It extends from the inner side of the retina, that is from the internal limiting membrane, till the eyes-OS junction. At the internal limiting membrane, the Mueller foot processes are in fact involved in the formation of the internal limiting membrane. And at the eyes-OS junction, the external limiting membrane is formed by these Mueller cells with their connections with the photoreceptors. So the external limiting membrane is not actually a true membrane, but it is just a junction that is formed by the connections between Mueller cells and the photoreceptors. So the third group of cells, which were the vascular cells, they mainly consist of the blood vessels that are in the retina. The blood vessels in the retina, they consist of the endothelium and the pericyte. The endothelium is the inner lining of the blood vessels, whereas the pericyte engulfs these blood vessels on the outer side and provide physical support. The endothelium forms what is known as the inner blood retinal barrier and is very much important in maintaining the compartmentalization of the intravascular compartment and the extravascular compartment. These pericytes are modified smooth muscle cells that surround these endothelium, as I had described earlier. And all these 3 groups of cells, they form a neurovascular unit, and they are involved in the autoregulation of the various metabolic activity, as well as the regulation of the blood vessel caliber. The pericytes have a number of functions, and these include angiogenesis and vessel stabilization, participation in tissue repair and tissue regulation. It has a role in blood flow regulation and neurovascular coupling, and it also forms the blood retinal barrier. So coming to the vascular layers, the vascular system of the neuroretina has mainly 3 groups of blood vessels. One is the radial peripapillary capillary plexus that lies at the nerve fiber layer. Then there is the superficial vascular plexus, which lies at the ganglion cell layer. Then comes the intermediate capillary plexus, and that is in the inner plexiform and the inner nuclear layer. And lastly, the deep capillary plexus, which lies in the inner nuclear layer and the outer plexiform layer. Another component of the anatomy that is very much important in understanding diabetic macular edema is the Henle's fiber layer. So the Henle's fiber layer is basically a bundle of unmyelinated cone and rod axons that terminate in this region and synapse in the outer plexiform layer. So these bundle of axons, they intermingle with the Mueller cell processes, and they are obliquely oriented at the region of the macula. And why does this happen? It happens due to the foveal pit development. What happens is during the foveal pit development, the photoreceptors migrate inward and the ganglion cell layer migrate outwards, thus forming this oblique orientation of the Henle fiber layer. So an important question we can ask at this moment is, what are the blood retinal barriers? Basically, there are two blood retinal barriers. One is the outer and one is the inner. The outer is formed by the tight junctions between the RP cells, and the inner blood retinal barrier, as I had mentioned earlier, is formed by the endothelium of the retinal blood vessels. So the inner half of the retina has a blood supply from the central retinal artery, and the outer half is supplied by the choroid with the help of the choriocapillaries. So the inner half till the inner nuclear layer is supplied by the central retinal artery, and beyond that it is supplied by the choroid. So now that we have covered anatomy, we can move on to the pathogenesis. So we know that diabetes is a systemic condition, and it involves a number of metabolic disturbances, all of which ultimately lead to proliferative diabetic retinopathy and diabetic macular edema. So the mechanism is rather complex, but we can try to make it simple. So first, what happens is that there is vascular dysfunction. So what happens is, due to basement membrane thickening, which is the first histological feature of diabetic retinopathy, there is damage to the endothelial cells and the pericytes. This leads to a endothelial cell and pericyte cell loss. So this results in the formation of microaneurysms and acellular capillaries, and these formation of acellular capillaries lead to ischemia. Ischemia then leads to your formation of increased VEGF and also neovascularization. So what VEGF does is it also causes the breakdown of the blood retinal barrier, and due to neovascularization there is advancement into proliferative diabetic retinopathy. Now, because of this breakdown in the blood retinal barrier, there is ultimately diabetic macular edema. So that was the vascular component. But so in diabetic retinopathy there is neuroglial dysfunction, and this leads to a number of metabolic disturbances, ultimately leading to the loss of neurons and loss of the neurovascular coupling that I had mentioned before. These also lead to your loss in endothelial cells and the pericytes, ultimately leading to the same result of microvascular dysfunction. Then there is another component of inflammation as well, and there are a number of inflammatory cells which lead to leukostasis, and these also ultimately lead to endothelial loss and pericyte loss, and then microvascular dysfunction. And all of these steps ultimately lead to your proliferative diabetic retinopathy and diabetic macular edema. So this is just a comparison of a normal eye and an eye with diabetic retinopathy. A normal eye, all the components are intact and there is no leakage of fluid or proteins. However, in diabetic retinopathy, due to all the dysfunctions that I had described before, there is infiltration of your RBCs, there is leakage of fluid, there is pericyte loss, there is migration of inflammatory cells, macrophages, all of which present with the clinical features of diabetic retinopathy. Also, there is an important component of diabetic macular edema that we should understand. In diseases like central serous chorioretinopathy, the fluid is limited to the subretinal space, as you can see here. Why does that happen? Why does it not go into the intraretinal layers? This mainly happens because in acute cases of CSR, the external limiting membrane is intact. Thus, the fluid is limited to the subretinal space. However, what happens in diabetic macular edema is that it is a breakdown in the inner blood retinal barrier. So even though the external limiting membrane is intact, there is fluid collection in the inner retina. So we had already discussed the clinical features of diabetic retinopathy. These usually include retinal hemorrhages. Then there is macular edema, as you can see with the dull foveal reflex. There is collection of these yellow precipitates. Usually these yellow precipitates signify that there is a leaking microaneurysm, or there could also be a diffuse leakage in that region and not simply from a single microaneurysm. So when there is any leakage, at the margin of the leakage, these yellow precipitates concentrate, and these yellow precipitates are mainly the lipid components. So as the fluid filters out from the inner retina towards the sclera, these lipid precipitates at the margin, and these might remain for a very long time until these are phagocytosed by the microglial cells. And obviously, if we do not treat it at this stage, then it ultimately leads to proliferative diabetic retinopathy. Coming back to diabetic macular edema. So there are a number of classifications, but the main clinical classification that we have been using for a very long time, and it was given in the ETDRS from the ETDRS study in 1985, and that is the clinically significant macular edema. So clinically significant macular edema, it has three criteria. Number one is that there should be a thickening of the retina at or within 500 microns of the center of the macula. Secondly, there must be hard exudates at or within 500 microns of the center of macula if there is adjacent retinal thickening. Thirdly, the zone of thickening, if it is larger than 1 disc diameter, and if it is located within 1 disc diameter of the center of the fovea, then we will also call it clinically significant macular edema. So now that we have learned the pathogenesis, we can go to the investigations. So investigations mainly in a routine clinical practice involves color fundus photo, an optical coherence tomography scan of the macula, fundus fluorescein angiography, or in some special cases might also involve the use of OCT angiography. So coming to the color fundus photo, it is usually done for documentation, and sometimes it might also be useful when we are planning for laser photocoagulation of, let's say, microaneurysms in an area. So the first image is a standard 55-degree photograph, color photograph of the fundus, and the second one is the standard 7-field ETDRS protocol photograph. Thirdly, we can also do the ultra wide field fundus photography, and it provides more than 200 degrees of field of view of the retina. These are mainly used for proliferative diabetic retinopathy conditions. Coming to the main investigation modality, that is optical coherence tomography. So the basic layers of the retina should be known before we move on to interpretation of the OCT findings. And here basically we can know that this is the retinal nerve fiber layer. Then comes your ganglion cell layer. Here is your inner plexiform layer. So inner nuclear layer. Is a outer plexiform layer, and also the Henle's layer. Then after Henle's layer is your outer nuclear layer. Here is the very important structure that we talked about, the external limiting membrane. Then comes your ISOS junction. Then this is your interdigitation zone. Lastly, the RPE and Brooks membrane. So based on OCT, diabetic macular edema can have a morphological classification, that is spongiform, where there are no cysts, or it could also be cystoid macular edema, where there are presence of polycystic intraretinal cysts, as you can see here. The third type that we can divide it is neurosensory detachment, where there is presence of subfoveal subretinal fluid. Another classification that can be applied is the center involving and the non-center involving, and this mainly involves the 1 mm circle of the ETDRS circle. If there is any thickening within this 1 mm circle, then it is center involving diabetic macular edema, and if it is present elsewhere, then it is non-center involving diabetic macular edema. The third type of classification on OCT of diabetic macular edema was given by Yahya et al., in which we can divide this into type 1, that is, there is only focal macular thickening. Then the second type, where there is diffuse non-cystoid macular thickening. And the third type is there is diffuse cystoid macular thickening, as you can see here. Fourth type can be divided into two, A and B. In A, there is tractional macular edema due to posterior highlight traction, as you can see here. In B, there is tractional macular edema due to epiretinal membrane, as we can see the membrane here. The fifth type is serous detachment, and there is collection of subretinal fluid. Another classification which has been given recently is the ESASO classification, in which they have divided the diabetic macular edema into early, advanced, severe, and atrophic. In early, we can see that the cysts are not that large, the edema is not that diffuse. In advanced, we can see that the cysts are larger in size, very big, with hyperreflective material in them. In severe, we can see there are giant cysts with Scheidegg retina. And in atrophic, we can see there is thinning of retinal layers. This ESASO classification also gives scoring for the various components, that is thickening, cyst, EZ or ELM status, drill, hyperreflective foci, subretinal fluid, and vitreoretinal relationship. And all of this scoring can give the staging, that is early, advanced, severe, and atrophic. So OCT also provides us with various biomarkers. So the first one is the central subfield thickness. It is not very specific and is not a very reliable indicator when used alone, but it is useful when we are using it with other biomarkers. Another important one is drill, which is the disorganization of retinal inner layers, and it mainly means that there is an inability to distinguish between the ganglion cell layer, inner plexiform layer complex, the inner nuclear layer, and the outer plexiform layer in the central 1 mm zone in a OCT B scan, as you can see in this image. So the other type of OCT biomarkers are hyperreflective dots. These are mainly important markers of inflammation, and in studies they have shown that if corticosteroids are used, then they have a better outcome than anti-VEGFs. Then there are intraretinal cystoid spaces, and these have been divided into small, large, and giant, and the size of the cyst has been correlated with extent of macular ischemia. Another important OCT biomarker are the bridging processes between inside the cysts. These have shown to have a better visual acuity after treatment. Then there are hard X states. These are basically lipoproteinaceous deposits, and studies have shown that if we give intravitreal steroids, they might be more effective in such cases. Then there is subfoveal neurosensory detachment. Here studies have shown that these appear to play an important role in protection, and they have seen that if there is presence of subfoveal SRF, then the visual gains are better at the end of 1 year with treatment. Then another OCT biomarker is the integrity of the ELM and the EZ. So it is a very important biomarker, as presence of disruption of ELM or ellipsoid zone has been shown to have a poor visual acuity after treatment. Then there is the vitreoretinal relationship. There is the taut posterior highlight, as you can see in this image, which is producing a vitreomacular traction. And these, if there is presence of this, then the patient might benefit from vitrectomy. Other OCT biomarkers are subfoveal choroidal thickness, hyperreflective choroidal foci, choroidal vascularity index, and the photoreceptor outer segment lengths. Another investigation that we can use for diabetic macular edema and diabetic retinopathy is fundus fluorescein angiography. In fundus fluorescein angiography, in the first image, we can see a lot of hyperreflective dots. These are basically microaneurysms. Then we can also see the leakage. Here, diabetic macular edema on FFA can mainly be divided into focal and diffuse leakage, as can be seen in the fundus fluorescein image based on the area. Another thing that we can measure with fundus fluorescein angiography is the size of the foveal avascular zone. Its normal range ranges from 400 to 700 microns, but in case of ischemia, there will be a distortion in the FAZ configuration, or there might be an enlargement. And not related to diabetic macular edema, but we can see another important finding in fundus fluorescein angiography in diabetic retinopathy is that leakage from neovascular vessels and CNP areas. That is capillary non-perfusion areas. Then fluorescein angiography can also be done with ultra-wide field, and it is very helpful in showing areas of ischemia in the far periphery. There are also a few OCT biomarkers. There is the retinal vascularity density, which is basically the area of retinal vessels present in the area measured. Then there is intercapillary spacing. There is the gap between the individual capillaries. Then there is the size of the foveal avascular zone and the fractal dimension. The fractal dimension is basically the arrangement or the orientation of the individual vascular capillaries. Here we can see in the first image that there is an enlargement and distortion in the foveal avascular zone, and there is appearance of these intercapillary void areas. Another finding that we can see in OCTA is the presence of neovascularization elsewhere. There is also in recent times there has been a lot of studies with the usage of artificial intelligence in diabetic macular edema. So in ophthalmology, we have a large database of image-based data. So these artificial intelligence models use something known as convolutional neural networks. So what convolutional neural networks is that there is an input image given, and these CNNs, they perform something known as feature extraction and then ultimately give you a result. So in feature extraction, what they basically do is that break down the image into a number of images and then use those individual components to find out the diagnosis or the interpretation of that image. So a meta-analysis showed that there were more than 53 studies done with regards to artificial intelligence in diabetic macular edema, and the overall sensitivity for OCT and fundus images was quite high, that is 96 and 94% images. AlexNet architecture achieved a 99.8% 98% accuracy in classifying healthy and DME OCT images. Inception ResNet version 2 achieved 100% accuracy in such cases. And there were other architectural networks as well, which performed quite good. So even personally, we have done a few artificial intelligence studies in classifying OCT images for diabetic macular edema, and with the help of automated machine learning, and we have seen that the results are quite good. So that was part 1 for diabetic macular edema. In part 2 we will be doing management of diabetic macular edema.